Good morning, and welcome to Treat Live. It's the first broadcast of the fall season. I hope everybody had a great summer. My name's Robert Lookstein. I'm Chief of Interventional Radiology here at Icahn School of Medicine in New York. To my right on the screen is my colleague and partner, Vivian Bichet. We have an incredible case to show you. I think everyone's going to learn something from it. I'm looking forward to it. And I think we're going to go straight to the lab and find out what kind of progress they've been making. Rahul,
right,
we
thanks,
can
Rob.
see you. Karema, we can see you.
Yep, perfect. Can you guys hear me too?
Yes, the audio is perfect.
All right, perfect. So we have an interesting case of complex filter retrieval. So again, as we start every case, I want to thank our nurses, our techs, our anesthesia support staff, the team from BroadMed, and obviously our patients for allowing us to share in their cases. The first case we're going to show today is basically a complex filter retrieval. So let me introduce Brian Pacheco, who's one of our PGY5 residents. And he's going to sort of introduce the case. To my left, I have Jade Lerner, and then I have our visiting medical student as well behind me here. So, all right, Brian, you want to take it off and show?
Yeah, perfect. We'll get started. Today, the case we'll be presenting is complex IVC filter retrieval via transjugular approach. Next slide, please. In summary, this is a 49-year-old female with IVC filter placed back in 2015, presenting for removal. Her past medical history is significant for Crohn's disease, status post-ileocolic resection in 2008, GERD, Hashimoto's thyroiditis. Social history is non-contributory and no known allergies. Next slide, please. This filter was approximately placed 15 years ago, around 2009 and 2010. Patient suffered major trauma in the setting of motor vehicle collision, including multiple pelvic fractures and solid organ injury, in which prophylactic filter was originally placed. Attempted removal occurred in May of 2010, but was ultimately unsuccessful. There were no further attempts of removal or retrieval, but opting for continued surveillance. Next slide. So we can click the next slide as well. So as you can see on our CTV here obtained this year, there are displaced filter limbs extending into the second portion of the duodenum and along the anterior wall of the abdominal aorta at the level of L3. Additionally, it looks like there is also a metallic strut completely detached from the filter, which lies superior to the filter within the IVC. Next slide. Next slide as well. And we'll do next slide as well. As you can see on a coronal and sagittal reef formats, the same thing I've discussed. We'll go next slide. So in assessment, this is a 49-year-old female with remote history of IVC filter placement in the setting of trauma, status post-failed retrieval in 2010. Things to consider for this case is the 15-year implantation time, additionally with the CTV concern for erosion of the struts and embedded locations of the hooks. Additionally, the retrievable hook is actually posteriorly oriented into the IVC. Next slide. And that's all we have.
All right. Thanks, Brian. So, yeah, it's a complicated situation. She's actually asymptomatic from all of this, even with that strut sticking into the duodenum. The concern for us, when we saw her was that, it's now fractured. And I think, if it wasn't fractured and it didn't have all these penetrations, I would say she could have the option of leaving it because she's done well with it for at least 15 years. But now that it's fractured and penetrating, I think we have to make an attempt to remove it. I don't know what Rob or Kremer, who else is there? Your thoughts?
Vivian.
Yeah, Vivian.
So I think this brings up a great question, but probably first and foremost, I was going to ask, can you share with us an X-ray image of what the filter looks like on fluoro, just so we understand how complex this is?
So we'll take a single shot. Our sheets.
I already did. Can you share what we've?
Yeah.
There we go. I just took it.
Can you
so
zoom in on that? Can you zoom in on that?
Yeah. Of course.
Yeah.
So that fully detached tine is still there as well.
Yeah.
So unless I'm mistaken, that's a Cook filter. So that's probably first and foremost. Yeah. And obviously this is a potentially retrievable filter. So these filters, unfortunately, we do see instances, especially after such a long duration, in this case, obviously 15 years, where you can have these rate of what I'll say is adverse events or unanticipated events. And in this case, and please correct me if I'm missing out something, you have a fracture, and you also have you have multiple stabilizing limb penetrations into the viscera and into the aorta. Do we have any documentation about whether the filter has migrated at all? Because obviously that's another consideration that we want to at least talk about when we're considering filter removal in the semi-elective setting.
Yeah, so from my understanding, it hasn't migrated. With the attempt at removal, there is obviously displacement. My guess is the leg may have broke during that removal, but it's hard to say because we don't really have the images from 15 years ago.
And just to be clear, she has no abdominal pain. She has no signs of sepsis. There's no concerns about that.
Nope, she's completely asymptomatic from all of this.
Got it. So this is an interesting question. I usually get concerned when there's documented erosion into the bowel at a minimum, and I think it's a little bit of a theoretical concern, but I think the concern is of creating a septic environment, in this case in the retroperitoneum, and what the long-term consequences of that are. Vivian, obviously you have a lot of experience here. When you see patients with filter strut penetration, how do you approach it? What's your threshold to try and come in and talk to the patient about taking it out?
Yeah, it's a lot about the adjacent critical structures more than the tines actually extending through, but to what degree it's extending through the wall. There's always going to be some extension out of the wall, but this is, as you saw in the cross-sectional imaging, there's actual penetration into viscera and critical structures. So the other thing here is that she doesn't have back pain, but there is actual periosteal reaction only at this level. So you're having changes in the spine directly related to this.
Correct.
And I think you put all those things together, probably the risk of maintaining it, especially with that one fracture, now becomes, greater than what they were doing, which is ongoing close monitoring and surveillance at the outside facility. I think you have to talk about retrieving it, which is obviously why she's here.
The other way of looking at it, and I agree completely with what Vivian said, as usual, is that, are we all comfortable letting this stay in for another 10, 15, 20 years? And if it's had this degree of unpredictable reaction to the surrounding organs in 15 years, what are the next 15 years going to look like? And so I would have a very candid conversation with the patient regarding risks and benefits. Obviously, we're a center that has extensive experience with removal of IVC filters, especially long-dwelling filters. So I think that does factor into the conversation. Rahul Karema, maybe you can share with us, how do you plan a case like this? This is clearly not a routine retrieval, and just, what's the setup? What ancillary pieces of equipment do you need? How do you troubleshoot this? Obviously, we've done cases similar to this, dozens, if not hundreds of times, but I think one of the great learning points here is, what are our lessons learned? How can we share with our audience, how to plan a case like this so you have the greatest opportunity for success?
Yeah, so I think someone's tried to snare this out, so we're not going to try and snare it. So we're just going to go straight to using forceps. It sounds like the people who tried before maybe tried something that may have been a hangman or something like that. I think given the fracture and everything, I don't think that's going to be such a great idea because we still have to get that free piece out. So what we did is we actually went straight to an 18 French Cook sheath that's long enough to get us past the filter. So we have to be able to obviously grab it, get the forceps down, grab it, and then sheath it with the Cook sheath. We put a groin venous sheath as well. And then sort of the way we plan it is we look at the orientation. So this is sort of pointing to her left shoulder. So we're going to, if we needed to grab it from below to rotate it off the wall, we're going to come from the right side so that we could grab it at the apex. We'll be pointed towards that apex, and then we can grab it and then spin it and then grab it from above to remove it. We've done with the option filters, we've done sort of filter inversion, which we've published on. I think with this filter that's already fractured, I would not really want to do that, to like rip it out from below. So we're not going to do that. We're going to try our best to remove this from above. We did put an arterial sheath in just because there is a time that has a significant reaction within the aortic wall. I think it may end up being overkill, but again, I think for these types of cases, we plan for the worst. So with that as well, we have an aortic occlusion balloon here, just in case if the IVC has an injury. For these cases, we always keep it in the room. Again, with the groin catheter, since we have a groin venous catheter, I'm able to keep an a wire across the area that's actually pinned up into the brachiocephalic vein, so that if there is disruption of the IVC, we're already across, so we're not trying to fight that to get it out. Or to get across, to get the balloon up and stuff. So again, planning
great
for the
teaching
worst,
points.
But, yeah.
Great teaching points. I'll let you all sort of get started, because I think there's a decent amount of work ahead. Vivian, I remember a time, certainly, as recently as 10, 12 years ago, where there were certain patients that we would actually refer and have evaluated for open surgical exploration of the IVC to remove a filter, similar to this. If there was a complex either fracture or a complex penetration, we would, not uncommonly refer the patient to surgery. I don't remember the last patient in our group that had to have surgical exploration, certainly the last patient in the campus. So what can you share about your experience with referring patients for surgery?
I have to say that might be a little bit before my time.
Okay.
Because I think that these are the kind of cases, just a little bit.
I think she just called you old, Rob.
Okay, that's fair. That's fair.
So I just wanted to, sorry, before Viv, you answer your question, I just want to show that Karemo was able to get that top piece out.
People.
So, exactly. So our point, the reason we did that is, one is free and it's above the filter, so we wanted to get that out. Actually, one other thing in terms of case planning, which I didn't go over, is actually we took a chest X-ray beforehand, more so for our friend Scott Nowakowski, but for medical legal purposes, that we could show that there was no pieces at the beginning and there were no pieces left at the end. So just in case if their piece breaks off, we have documentation that if we go back and look and say, oh, was that piece there before, we sort of know whether it's there before or not,
And that was a free floating little piece, so it came out pretty straightforward. Yeah. So
I guess the question is, what is the data on the outcomes for that versus this? I think I know the data for this that we've published, and other centers that do advanced filter retrieval, and that we can do it safely. So in experienced hands, I think this can be done this way, but the question is, how morbid is it to the patient to do an open type of surgery? And
so interestingly, she was referred by a surgeon here who did offer her an open removal, given the fact that it's fractured and penetrating. But obviously we're going to try this first to see. But I agree with Rob and Vivian. Can't remember the last time we've sent someone for an open removal of a filter. So again,
do you have the ability?
Using
go ahead, but while you're getting around or getting stabilized or getting set up, do you have the ability to show the actual piece that Karemo was just able to retrieve? I'm just curious whether or not it was a centering leg or a stabilizing leg. It looks like at least on fluoroscopy, it's not the centering leg. It's the longer stabilizing leg.
Yeah, it's the longer stabilizing leg. I don't know if you guys. Let me see if I can put this on the blue.
No, we can see it.
Yeah, on the blue towel.
Yeah.
It's definitely got a hook on it, so it's definitely one of the main limbs.
Right.
And in our pictures, you can see which limb it kind of was. Yeah. Thank you. Right, there you go.
I think it's a minor point, but I really, your amplats that you have from below, it's nice that it's not in your sheath while you're working, because it can kind of get in the way when you have it from above.
Okay.
So having that safety wire from below is a nice.
You think you have enough curve? Very good.
Vivian, that's a really good point. And I've
Good, more.
spoken to a number of people, not only in the United States but outside the U.S., and not a lot of sites use this as a safety wire. Could you just share a little bit about the rationale to using the safety wire and what it allows the operator to
A
do
little higher.
from a safety point of view that is an improvement on the technique as compared to, for example, not using the safety wire?
I mean, I can speak to, I don't know if Rahul wants to, but this was a tenet of my training to always have a wire across, right? Like if there is some injury to any kind of vessel, you want to have that ability to quickly go in, put a balloon up, do whatever you need to do. That'll give you some time to kind of think of a next step. So, and having it from below or above, that's a separate question, but that just is a kind of ease of work that you don't have that wire next to your forceps. But I think it's safety is paramount in these, and having that wire gives you that ease of being able to care for the patient if there is any injury to the vessel.
There you go. Yeah.
So that
kind of went fast, but Karema's too good. So we were able to get out. So what we did, I'm going to show a little bit just so we can talk about it a little bit. So we use these forceps. They're made from Limol, which apparently doesn't make them anymore. They come straight, and we bent it a little bit. So what she did is she sort of swept around to sort of free it a little bit, and then grab the hook.
Just want to cheat her.
I don't know if you can see here, but there's a lot of fibrin on the hook itself, which sort of was making it up against the wall. And so now we'll do a venogram, and I think we'll do an aortic.
Can you zoom in on the? Yeah, I think we're zooming in on the filter right now. I'm surprised that there's not a lot of tissue on the limbs itself. It looks like all the tissue is on the actual apex of the filter, which is a little bit surprising. So
there's a little bit on one of them. Yeah.
As usual, you both just make it look so easy. It's a incredible testament to your experience. I think there's a number of questions that come up. First is, how do you document that the patient's safe? And then second is, how do you document that you didn't leave anything behind?
Yeah, so again, we took a couple single shots of the filter beforehand. We'll repeat the chest X-ray, so imaging of the chest, just to make sure no free pieces have come off. So we'll do that now. We take a single shot chest X-ray here. Also, I didn't really talk. We did talk about also the level of anesthesia. We tend to tube patients for these, just because it allows us to be aggressive. We've tried to do them with more on the awake side. They tend not to like it. Yeah. So, and then let me give it the pigtail. And then we'll do an aortogram just for completion's sake. Can I get the Benson?
Excellent.
I think the intubation is also for safety too, because if there is any instance where you need to move more quickly, like having that happen after the fact is not great. So it's all this upfront preparation that really makes this look easy, but it's really the most important part, I think, in addition to the technique is, okay, so you have the wire across. What are other things that you've thought of doing, right? You guys have a balloon in the room. You maybe want to talk about those things just for the audience members who aren't really doing this kind of work.
Yeah, so we have an aortic occlusion balloon, so in case the IVC disrupts. I'll be honest, with the actual removable filters, we haven't really seen that. But it can happen, and we just want to be prepared for it. We do have covered stents available. They're not in the room, but they're very close by.
So Vivian, to your point, obviously we don't put every single filter removal under general anesthesia. In your practice, how do you make a determination that somebody needs general anesthesia? What's the sort of clinical algorithm that you go to decide that this is going to be a more complex case? Maybe we need a full anesthesia setup.
Sure. So, I mean, in this case, the failed previous attempt, I think it basically puts it in another category unless you look at it and really can't understand what transpired, and you think you know that the tine is not embedded and it looks very clear, then maybe you make another attempt at a straightforward just snare. But anytime I'm doing or planning, thinking there's going to be forceps involved, which again we kind of talked about all the features of this case that make it clear that you're going to jump to that. The forceps, the patients don't tolerate that the stiffness of the forceps very easily anyway. So these patients are going to be intubated when you're putting a sheath that's 18 French.
Contrast.
Those patients are probably, you're going to want to just have them paralyzed and doing it without them sort of involved in the procedure.
Those are great points, Vivian. Thank you. Rahul, can I just ask you, could you do a slightly more focused view of the infrarenal aorta, since I think that's where the limb was actually penetrating? I don't know that I can clearly identify that the infrarenal aorta is totally normal.
Give him one more mag.
Sure. Yeah, and the other question that comes up for early users or people who don't do a lot of this is, how hard can you pull? So I'll ask that question. How hard can you pull, Rob?
I'm not an engineer, so I can't answer that. But I think we all have gotten comfortable pulling, fairly hard. And I know there's people that document the actual, force that's being used and quantify it that way. I think that the forceps have really revolutionized this. I know there's other techniques, the excimer laser amongst others. I don't think that we've really felt that that's been necessary on the overwhelming majority of the cases that we are doing. Just a personal note, I think Rahul remembers this case. We had a case where a permanent filter had eroded similarly through the viscera and through the aorta, and upon retrieval, unfortunately, we documented that there was an injury to the lumbar artery. One of the legs had actually transected the lumbar artery, and so it's one of the reasons why I get very meticulously focused on these lumbar arteries and the infrarenal aorta, and obviously in this case they look completely normal. But I think if you're going to do a retrieval where there's a documented limb, clearly through the wall of the aorta, I don't think you can wake the patient up without doing a focused aortogram.
Yeah, I mean, the other thing is that it helps, if she goes back there and she starts to have a little bit of back pain or abdominal pain, we sort of know, the aortogram was okay. Not to say we wouldn't continue to monitor her, but it gives you a sort of a level of comfort,
And then what about, this ended up coming out pretty easily, but what do you do with anticoagulation for patients if you think you have to do a complex filter retrieval?
So she wasn't on AC at baseline, so we gave her a little bit of heparin during the procedure just because as we have these bigger devices in, we don't want her to form clot. For us, everyone's a little different. I think my preference is actually not to take them off their AC for this. Some people will transition them to Lovenox and then basically give them heparin during the procedure. But I think everyone's a little bit different. I think if it's super complicated or for a non-retrievable filter that's very embedded or very stuck to the wall, I think maybe we stop it and have better control over AC. Rob, Vivian, what are your guys' thoughts?
It's a tough question. I think if you're not going to give anticoagulation, you have to be very vigilant about clot formation, especially in your sheath, because that will happen very easily when you have a larger sheath in. So just being very mindful of that and continuing to flush it throughout. But it just depends on your comfort level with how, like you said, if it's a permanent filter, maybe not. And if it is retrievable, then how likely do you think it is to cause a disruption that you wouldn't want them to be on anticoagulation? But the safest thing is always just to, if you're concerned, to convert them to a short acting and then giving in the room when you feel there's a opportunity where you feel safe to do it.
Yeah, I would just add, I personally don't think that I would do a case this complex if somebody was on a full therapeutic dose of a DOAC. I'd probably transition them. Anything that's less complex than this, I think it's fine to do it even if they're on a DOAC. But I get worried when the tines are through the aorta and through other structures, just about the safety issues with a full therapeutic dose of that. So Rahul, you actually brought this up, but I think it's a really good point. And you've done a lot of these cases. What happens if the patient has 8 out of 10 back pain in the PACU? How would you work that up? And then how do you counsel the patient after the procedure, when you see the patient in office hours, of, what kind of side effects they might feel, what kind of constitutional symptoms they might have? What's been your experience? Because obviously this is not a routine, simple case.
So, before the procedure, I explained to her that she may have some abdominal and back pain, some soreness afterwards. Usually that goes away pretty quickly, just from the tension or the inflammation of removing it out. Neck pain obviously is always there, just given the size of the sheath that we have in there. If she does start to have severe abdominal pain or back pain there, I have a relatively low threshold to just get a CAT scan. And just put it to bed, right, one way or the other. I think trying to say like, oh, we'll just give her some medicine and see how she does. You may miss something, and it can get bad really fast. So I have a relatively low threshold for CT scans. I'll be honest, and even in these complex filter retrievals, I haven't had any patients come back and complain about pain or discomfort afterwards. So, yeah.
I think that's such an important point that you make about the low threshold to getting a scan. I mean, we have access to the technology. We're in the facility. There's really no argument to be made in my mind to not just, getting the imaging and satisfying the question that way or answering it that way.
Yeah.
Agree.
Yeah. So are you guys done? You about ready to close up?
Yeah. Yep. So we just pulled the two venous sheaths. We're just holding pressure, and then we'll just use a closure device on the arterial side. Yeah.
Fantastic. Can you just give us one last final shot of the filter and the fragment that you took out, just so we can document it, and then I think we'll let you all go.
There you go.
If we could zoom in on that. There we go.
Prem, I made it look too easy.
I know. It's a testament to how great you all are and how experienced of this. And I think one of the closing messages that I would share is that if you're doing this in your local neighborhood, your local backyard, and you're either unsuccessful or you don't feel like you have the resources, it's a good idea to think about referring the patient to a very experienced center that has the resources, that has the experience to do these cases, instead of going, for example, directly to a retroperitoneal exploration. I think there are a number of emerging centers across the United States, globally, that are really well trained and well experienced to do these very complex filter retrievals safely, and I think this is really the dawn of a new era where nobody should be at least evaluated for surgical exploration as first-line therapy.
I agree.
All right. As usual, you all make it look so easy. I want to thank everybody here. I want to thank my co-moderator Vivian Bichet. I want to thank everyone from Broadmed AV to just putting on such a high quality production this morning. The production is just so good, and they're such valued partners. So thank you all at Broadmed AV. But on a more practical note, I want everyone to have a great weekend, and we will see you next month. Take care, everybody.
Thank you.
Thank you.